Shall we begin? Did anybody have questions before we dive into stuff? Or was that a random hand? Did I post what? No, I haven't yet because I haven't written them. I am finally just getting caught up with everything. So tomorrow I'm hoping to write notes for today and last week, and as well as the videos that I have done. Unfortunately, you guys got kind of the short shrift. I've gotten everybody else's stuff pretty much done. And that you ended up on the end of the list because I had a whole bunch more work to do for this class because I hadn't gotten things set up for it before. But we'll get there. We'll get there. So at least I'm getting slides posted, and I'm hoping that they are, yeah, I know. They're never self-explanatory, but at least I hope they tell a story. So aside from that, no, I haven't posted notes and videos yet. Any other actually, that wasn't an irrelevant question. Any other relevant questions? Should we just go for it? All right. So we're going to do kind of a review of the antidysrhythmic drugs. We're going to talk about fluid and electrolyte balance. I actually have, in my program, I had this handy little book called, amazingly, Fluid and Electrolyte Balance. And I actually had it in my locker in the ICU for 5 years. And I referred to it from time to time about when this happens, you can expect that to happen. It was very useful because you can't remember all this stuff. You really can't. Unless, even if you remember a lot, you're going to run into situations where a patient comes in and you're going like, wow, I've never seen that before. Somebody comes in with a calcium of like 12. What's going on? Well, it turns out they have bone mets and everything's breaking down. It causes all kinds of problems. Okay. So, you may have noticed especially in conversation, not so much in the reading, but you'll hear dysrhythmia and arrhythmia. I mean, technically, arrhythmia means no rhythm. Asystole is arrhythmia. Dysrhythmia means disturbed. However, they tend to be used interchangeably as people, he was arrhythmic and this was going on. He was in, AFib and VFib and whatever. So don't let that throw you that people are not clear about those terms. They're kind of used interchangeably. Have any of you ever run across that where somebody's talking and you're thinking, he just said arrhythmia, but the patient had a rhythm. And it wasn't even particularly disturbed. Okay. So let's talk about the 4 functional classes briefly. No, we're not going to talk about those. You have those in your book. The 1, A, B, and C, and the different kinds of drugs that are antidysrhythmics. And what's the most common side effect of the antidysrhythmics? Dysrhythmia. Yeah. Okay, good. I knew you knew that. But I kind of like this picture, and I think I actually pulled this out of the Med-Surg book, not the Pharm book. I've been kind of using both, but it's the same text you all have been using for the last couple of years, talking about where the different drugs act in the action potential. Now, your action potentials in the membrane, the shapes are a little bit different depending on whether you're looking at the P wave and the R wave, But this is generally what's going on. You've got potassium and sodium moving in, and sodium moving in, calcium moving in, and then things start moving back out. And when you're talking about sodium, calcium, and potassium channel blockers, that's what they're talking about. And you can figure out where they are going to act based on this wave here. It's just, it's handy information. The calcium channel blockers are going to slow calcium conduction, the calcium down. So if you look at it, you say, that's happening kind of, more or less at the top of the wave here. That's where the calcium channel blockers are happening. Potassium is kind of throughout, obviously. Where do the beta blockers fit into this? Anybody want to make a guess? Oh, come on, you guys. I know you guys. You're all really bright. Somebody hazard a wild guess about where beta blockers fit into this picture. Yeah, they're not in here at all because they're in the autonomic nervous stimulation. They're a different part. They don't have any direct effect on the conduction. They have an effect on the initiation, which is happening elsewhere. I really tried to get this stuff to fit. So you probably want to go look at page 405 in Lilly. So that's the pharmacology book. Because here are your effects of your antidysrhythmic drugs by class. And even with my glasses on, I can't read this. So class 1A, which you're not going to see very often, but they change the myocardial excitability, decrease the. So what's an inotrope? What do inotropes do? Say that really loud. Yeah, that's what. When you're talking about heart stuff, inotropes, chronotropes, they always mean the same thing. So something. What is? Okay, so it's the strength of the contractility. So these drugs decrease the inotropic effect. Your heart's not going to beat as hard. Others are increase the inotropic. They increase the strength of the contraction. Chronotropes, of course, manage speed. Speaking of beta blockers, are beta blockers a chronotrope? Definitely, yeah. They slow the heart rate down, regardless of what's happening on the outside. They reduce cardiac output because they slow the heart rate down. Class 1B is, lidocaine. Well, you're not going to see that. It's considered kind of an outmoded drug, but you will see it used on occasion. No, okay, that wasn't a question. That was a sneeze. Okay. But you'll see people using diltiazem all the time, which is class 4, and those are, of course, calcium channel blockers. Amiodarone. That extends the refractory period. So when you say something is refractory, what does that mean? Should I start picking on people? No, don't do that. So refractory means it won't respond. So if you want to get somebody's attention in the ED, you've got a friend that's in pain, and they're not getting the treatment you think they should get, tell them their pain is refractory to the narcotics. And you'll get their attention, because that means it ain't working at all. Now, if you're talking about the QRS complex and the T wave is where it's refractory. When in that stretch, if there's an impulse that comes down from the brain or from your pacemaker and it's in the refractory section of the recovery, nothing's going to happen because the heart won't respond. It can't respond to it. And of course, with amiodarone, the reason you care about that is because as you get past that refractory period, it becomes semi-responsive, and that's where you can get into the R on T, which can lead to torsades. So these, if you have a patient on amiodarone, you really are paying close attention to the QT interval because it matters, and you're looking to see where things are happening. And if you start seeing, QRSs that are happening close to that T wave, that you need to be talking to the doctor about it. Yes, it's okay to call the doctor, but now you have something to say. You say, "Hey, doc, I'm noticing, Mr. Jones is having these, either the PVCs or whatever, but they're right on the T wave or getting close to it. That should be scary." Any other questions about antidysrhythmics that I can remember how to answer off the top of my head? You know it all. You're good for your quiz or your test next class, right? Okay. All right. So let's talk about fluids and electrolytes. Now this goes all the way back, to what you learned in physiology. Total body water. That's your fluids. 60% is water. Really. So that means I'm carrying around about 110 pounds of water here. I wish I could lose the other part more effectively. So what's the ECF? Extracellular fluid, right. And the ICF? Intracellular. So we've got these different areas. We got stuff inside the cell, outside the cell, and extracellular. Does that include the vasculature, or is that interstitial? It's mostly interstitial, I think. All of a sudden, I don't remember. You get old, your brain goes away. Okay. Are you making comments about me? No. So let's talk, you guys have heard people talk about crystalloids, right? They're giving the patient crystalloids. The question is, do you all remember what crystalloids are? They're basically salt-based. These are your electrolytes. So you've got saline, lactated ringers, hypertonic saline, D5W. These are all things that are just dissolved in the water. And they're really just used to maintain fluid balance. And you're going to use hypo or hypertonic fluids depending on which way you want the fluids to shift in the tissue. So if you got that as, we'll talk about the ascites patient in a minute, because, thinking of crystalloids, particularly if you work in critical care, you will hear people talk about a patient being vascularly dry. Anybody want to guess what that means? Oh, come on. I know you're awake and you're focusing. Yeah, sure.
Maybe they don't have that much fluid in their vasculature, but they have a lot of fluid
elsewhere. Yeah, so that is the ascites patient. They can't hold on to the fluid. So in terms of what the heart is having to do and stuff, that the blood is actually probably a little more viscous. It doesn't have as much fluid to dissolve. Well, you don't dissolve red blood cells, but to carry them. And so they will be vascularly dry, even though they've got, have any of you heard somebody with ascites really actually slosh when you turn them and stuff like that? It's really weird. But yeah, you can hear the fluid sloshing back and forth, especially if they're, really big. So crystalloids, like I said, are usually they're electrolytes as well, in general. And people don't, nobody is allergic to saline, as far as I know. That would be a real problem. So basically, you can give saline to anybody pretty much at any time, unless they're fluid overloaded. So if you're worried about the heart and the lungs, those may be issues, but they're not going to have a reaction to it, right? And kind of the same thing with most of the electrolytes, potassium, calcium. They will have side effects, but people aren't allergic to potassium. Now, if you're running it through a peripheral IV, they may be yelling at you about how much it's burning, even if it's just 10 milliequivalents in 100 mLs. Some people will still have phlebitis from it. They'll really be sensitive to it. Would somebody want to hazard a guess as to, can somebody come up with, or among you, can I get 2 ways you might be able to relieve that discomfort and still give them their potassium? I hear voices. You can infuse it at a slower rate, although you may need an order for that. Because you actually have an order that says over an hour, right? So if you start over 2 hours, and I'll get to you in a moment. Well, there's a couple of reasons. One, that you're no longer following the order, and if they're hypokalemic, your order actually may be for 40 milliequivalents in 4 bags over 4 hours. So if it takes you longer for the first one and the second one, all of a sudden, instead of having a 4-hour infusion, you have a 6 or 8-hour infusion. But that's one option. That's actually probably not going to make much difference. What's your thought? So if they've got another drip, if they've got saline running, is that what you meant? So, yeah, if you at the Y site, if you run them through the same line and your saline's running at 50 or 100 an hour, that will serve to dilute the potassium. You don't need an order for that as long as you've got an order for the other drip. One other thing you can do as a patient advocate is you might talk to the doctor about adding a little bit of lidocaine to that drip. Now, of course, that could have, dysrhythmia issues, but that wasn't an uncommon approach, which basically you just sort of anesthetize the vein a little bit. So if you go with the lidocaine, is that actually preventing the inflammation, the phlebitis? Or is it just masking it? Yeah, it's just masking it. So you may still have issues down the road. Okay. So let's talk about colloids. These are generally things that have proteins. They're large molecules. They're the ones that, pull the water into the vasculature. Think albumin, certainly. So they're too big to go through that vessel wall, and they, in particular, albumin, have the job. One of their jobs is to hold onto fluid. What's the other primary job for, if you want to call it a job, for albumin? What else does it actually? What does it actually transport? Not necessarily. Good. I mean, that's a fair guess. So albumin's involved in the transport of chemicals that don't mix well with water. In other words, it'll transport, the fats and other stuff that when you mix it with water, they don't mix. I'm sure that's really important as part of pharmacy. No, actually it is, because some drugs depend on it for transport. But, it's good to know about how albumin really works and its role beyond just being something to manage fluid balance in the body. It actually has a more it's not more important, but another important role, which is to help transport some of these hydrophobic chemicals. Have any of you used anything other? Anybody given albumin yet? No. Okay. Then you probably haven't given hetastarch or dextran either, right? Okay. So dextran, hetastarch, you will see those used particularly after cardiac surgery as a way to expand volume, because these people, I'll tell you, the post-op cabbage patients, they come out and they are third spacing like crazy. My recollection is over an 8-hour shift, we might give them up to 3 or 4 liters of fluid. Because at the same time, they're peeing it out. And part of that's because they use some of the osmotic diuretics as well, mannitol, which the kidneys are going to clear. because we can't metabolize mannitol. It's a sugar that we can't really break down. But again, it serves to pull fluid into the vasculature, and until we get rid of the mannitol, everything, you just keep peeing stuff out. When you give albumin, make sure it's room temperature. And I have to go back and look as to why, but the first thing that comes to mind is it's already very viscous. And if it's coming straight out of the refrigerator, it's probably really not going to flow. But I'm not sure if there's actually a physiological reason that it needs to be warmed up. But, in general, the drugs you give to your patients should be somewhere close to room temperature. Even if you're mixing through through a central line, it's better than if they came out of a, 35-degree. Our body doesn't really like to have really cold stuff injected into the heart, typically. Anybody had a patient that was hypernatremic yet? Yeah, I saw them all the time in med-surg. Yeah, okay. Yeah. So what were they doing? How were they treating that? Why did they want to restrict it? I was going to say that sounds a little backwards, but I did say hyper. So did you had a hypernatremic patient? Where they were actively, you didn't have a patient, they were actively treating it. So the order you'll often see if somebody comes in and they're dehydrated and they're hypernatremic because of it, the order will often read, well, it won't be an order, but you'll see in the progress notes that they're doing a gentle rehydration. The expectation is it will take a day or 2 or 3 to get their sodium levels back to where they belong. Why don't you want to do it quickly? Is it dangerous to change sodium levels rapidly? Yeah. Either direction, doesn't really matter. But yeah, I think if they are, I'm trying to remember which one leads to neural, demyelination. I don't remember, so I'm not going to say something stupid like it's one and when it's the other. Okay. But basically, the electrolytes to a degree are controlled by the renin-angiotensin-aldosterone system, which manages fluid balance, just, water retention and, what's going on in the body. What time is it, by the way? Because that clock is useless. So I've got like 15 minutes. Okay. I wonder if I have enough slides here. I may have to just stop talking. 25 minutes? See, I can't even do math today. Okay. So, if they've got problems with that system, what kind of a patient might have problems with their neuroendocrine system? I hear mumbling. Yeah, to a degree, but I'm focusing on the neuro part here in my thinking. Does that help at all? Yeah, well, it could have a secondary effect like that, but there's an area of the brain that is directly controlling stuff. And how about the syndrome of inappropriate? What causes that? Which gland? Isn't that like the pituitary that manages that? So if they've had brain damage, if they've had cancer, if they've had, radiotherapy, they are at risk. And of course, Of course, they're peeing like crazy all the time. Yeah, okay. So we were just talking about potassium. You really want to be cautious about your potassium infusions. Now, it used to be, and this was even predates my nursing experience, which is actually fairly short. Nurses used to go to the med room, and there was a bottle of concentrated, vial of concentrated potassium, and they would make their own drip. They'd draw up the potassium, put it into a bag of NS, and sometimes we killed patients because people made a math error and gave them 10 times more than they should have. Or bottles, the vials were labeled in such a way it was easy to mistake one for the other. And that's why when you read about to err is human, you'll read about those kinds of errors where to a degree they were built into the system. The way the system was set up, it set people up to make errors because it was easy to grab one instead of the other. And of course, you're busy, you're in a hurry, or there's a situation going on that's, you've got like 6 things in your head, they're all critical, and the patient's not doing well, and you have to run in and get something out of the med room. Those are not the kinds of situations that are conducive to making smart, well-considered decisions. It's just like on the med math when you slip a decimal point. It's wrong. The difference is here, when it's wrong, you can kill your patient. So what's happened is they put new systems in place. Of course, you now have the Pyxis, which, in theory, by the way, I have pulled drugs out of the Pyxis that were the wrong drug or the wrong concentration because the pharmacy tech made a mistake and put the wrong thing in the wrong box. So you still have to check. But the other thing is that, these drugs like potassium and stuff, they come up in pre-mixed bags. We no longer go to the medicine cabinet, open it up, grab a vial, draw stuff up, and mix it into the bag. That's actually extremely rare now. It might happen, it might happen in the ED. And, of course, the OR, it's a whole special world. When Kaiser went with Epic and, started Health Connect, the only unit throughout the system that said we're not going to do that was the OR. All the surgeons said, no, we're going to do it the way we've always done it. So you'll get a patient back from the PACU, and they got these hand-labeled bags where they have done exactly that. They've drawn up the epinephrine, they've drawn up whatever, and they injected it into the bag, and they occasionally make mistakes. So there was this real, and it continues, real resistance to letting an outside entity double-check them or even control how, the rationale was when things are happening and we're in a rush, we can't wait for it. We have to do it now. Which is why sometimes patients die in surgery. Or shortly thereafter. By the way, the surgeons, we should never broadcast this particular tape. Surgeons will do anything to make sure that patient didn't die in the OR. I mean, they'll come up into your ICU while they're actively coding the patient to get them into the ICU. So the statistics are, well, they died in the ICU, they coded, and they died in the ICU. They didn't die in the OR. Really, surgeons are really sensitive about those statistics. Of course, the cardiologists are really sensitive about 30-day survival rate after a code in the unit. So everybody's sensitive about how their numbers look. When you're giving potassium, it needs to always be diluted. Now, you'll often find, like on the floor, you'll give, like I said, 10 and 100. In the ICU, you do have higher concentrations available to you, but they are high alert. They require 2 signatures. And they must be given through a central line. And I think it was 50. I used to give 50 and 100 over an hour, as opposed to 10. So, and if you're given those drugs, you are paying attention to their cardiac rhythms, because there's a risk there. No, the reason you're giving them that is they were seriously depleted. They weren't just, they weren't 3.3. They're 2.7. Okay, well, let's see if I can remember how to do this. So, hypertonics, you want to be careful with hypertonic for those who are really hyponatremic because it can lead to demyelination. I thought I had it in here somewhere. I don't rely on my memory for much of anything anymore, which is, anyway. So, just as with potassium, you're paying attention to the rate and concentration of what you're giving. So if you're doing fluid replacement, what's always in the back of your mind? Somebody tell me what's one of the things if you're giving boluses and you're giving stuff at 100, 125, 150, 200 an hour, what in particular are you paying attention to? Yeah, that's okay, because you're on the right track. But I'm thinking, is there a reason you're doing this? Lung sounds, yeah. You want to know, are they starting to gurgle? Are they fluid overloaded? How's their heart doing? I probably told this story last year, but I may tell it again. If you're bored, you can tune out. I got a call from the cath lab. And they had just finished with this patient, and the nurses gave him a report and said, well, she's been a little, she's having a little trouble with her oxygen. We took her off a nasal cannula, put her on a non-rebreather, but that's fine. And our cath lab was, I don't know if it was 1 or 2 floors below, but we had a direct elevator into the unit. So, I got this report that she had gotten, I think it was just 500 mLs of saline during the procedure. The elevator door opens. She's on the gurney, and they're pushing her out, and she's trying to climb out of the gurney. She was suffering from flash pulmonary edema. She was dying, and she knew it because her lungs had just filled up with fluid. And, I just looked at the intensivist. Yeah, we need to intubate her now, which worked. We got her intubated. She got Lasix. She was on ventilator support. 2 hours later, she was fine. But 15 minutes without treatment, she would have been dead. So it was, it was exciting. I don't actually like exciting in the intensive care. That's why I don't lane split on my motorcycle. That's why I don't work in the ED anymore. That's why I never worked in the ED. I decided I didn't need the adrenaline rush. I got enough adrenaline in the ICU where it was occasional. I didn't need it to happen all the time. Now, if you guys need the adrenaline to keep you going, well, then that's what you do. Or you're a life flight nurse. By the way, life flight nurses, the ones flying in the helicopters and stuff, they have a much higher mortality rate because they crash all the time. Not all the time, but with a... The plane, well, particularly helicopters, because they're landing in areas that are not designed for them to land. So they have or they're flying in storms. They're flying in conditions that most people don't fly, landing in places where people don't land. And so, they have a much higher accident rate and a much higher death rate. So if you want to do that, at least, think about it. Okay. I like all of you. I don't want to hear about anything happening to any of you. So, if you're going to be looking, we're back to sodium. Depending on how hyponatremic they are, your first approach is going to be oral. Give them salt. Give them salty foods and salt tablets rather than running an IV. If they're more severely depleted, then you're going to have to do a cup. But it is done slowly. And, when I was doing I didn't usually get these patients in the ICU, but when I was working as a discharge planner, I would see these patients, and it generally was expected to take like 48 hours to 72 hours to get them back up to where they needed to be. So we were just talking about fluid overload. What you're looking for? Shortness of breath, crackles, decreased pulse oximeter readings. Why would you get a decreased pulse oximeter? Yeah, they're having gas exchange problems. Exactly. And of course, edema. Edema and increased weight. Those are things that are happening over a longer time span. But again, if you're giving if you're giving boluses and rapid infusions, you need to be really paying close attention to the lungs, in particular. If you're going to have somebody that is on fluid therapy for a while, you need to have a baseline for their H&H, because it will change. Have any of you heard any of your nurses talk about an H&H that was dilutional? Again, this typically happens in critical care. So they come back, and their H&H is low, but you've been giving them 250 an hour for the last 4 hours, so they have an extra liter of fluid. That dilutes the blood. So when you get that critically low value coming back from the lab, the doc says, yeah, okay, fine. We didn't transfuse patients in the cardiovascular ICU until, their hematocrit dropped below 23, I think it was. When I first started working there, I was like, wow, But they are so fluid overloaded because of the third spacing and everything else. They're getting all these fluids. It's like, no, actually, they really have enough red blood cells there to carry the oxygen around. It's just there's so much extra volume. And you'll see this like with sepsis patients. The sepsis protocol is you just, aside from the antibiotics, you give them a ton of fluids. I've seen sepsis patients, weigh 10 kilos more the next day. That's 10 liters. That's a lot of fluid, or hopefully their lungs can tolerate it. And I mentioned about albumin. Give it at room temperature. So you'll see up here, I say, look at your med-surg text on where these things act. We're moving on to antihypertensives now. We have transitioned out of fluids and, yeah. Mm-hmm. What does dependent mean? Well, you probably don't know that, or you wouldn't ask me that question. So something that is dependent is lower. So if they're sitting in the bed and their head's up and their feet are down, you'll see lower extremities. Typically, the lower extremities are considered to be dependent. But if you let your hands hang down, they are now dependent. They're below the heart. So anything that's below the heart is dependent. I'd have to stop and think about the origin of that actual term, but it's gravity. Gravity wins. So let's move on to antihypertensives. I was about to ask something I can't, so I'm not going to do that. I really wanted to put this up here, but it would have taken, I couldn't figure out in the time I had how to do a 3-page chart. It would have been 3 or 4 slides of where these drugs act. And again, this gets we're kind of going back to some of the stuff similar to what we were looking at with antidysrhythmics. What part of the system do they act on? Now with the antihypertensives, there's a lot more places for them to act than just in the conduction pathways. So you've got your diuretics. You've got loop diuretics, potassium sparing, and of course the ARBs, aldosterone receptor blockers. What's characteristic of loop diuretics? What do you give all the time that's a loop diuretic? Lasix, right. Furosemide. And what are you paying all your attention to with that patient? Potassium, yes. See, we're back to potassium. It all the world revolves around potassium. Potassium sparing. So if you have a patient that's on a potassium-sparing drug and they have a high potassium diet, they're going to have the opposite problem. What kinds of things have a lot of potassium in them? Banana's one, yeah. What about orange juice? Most of your citrus fruits are high in potassium. That's why I used to use orange juice for those patients that were going to get oral potassium. I figured it wasn't going to hurt. They were depleted anyway, and if you're giving them like the potassium elixir, it still tastes terrible, but it doesn't taste as bad as mixing the elixir with apple juice, which is really gross. They will tell you that, by the way. Okay, and adrenergic. Some days I can say that. Adrenergic inhibitors. So these are your beta and alpha blockers. Peripheral, non-selective, mixed alpha, direct vasodilators. It's a long list of drugs. I'm not even going to begin to cover those individually. But again, this gets back into knowing your drug classes. Because these are the kinds of things that the NCLEX expects you to know. You should know how beta blockers work and where they act, what receptors they work on, whether they're beta 1 or beta 2 or both. So some of your beta blockers work on all of the beta sites. You know, they have not just a crossover effect. I mean, it's just they hit both the heart and the lungs. So you want to know which drugs those are because that it impacts how you're going to follow that patient when you're providing care. ACE inhibitors. What's the most common side effect that people complain about with ACE inhibitors? Cough? Is that what you said? You said it. Yeah, that dry cough. Yeah, that's the cough. I know it well. I used to take lisinopril, but that was exactly the problem. I was fine during the day, but I'd lie down, and that tickle at the back of my throat, and I would just, trying to go to bed, start coughing. It was really irritating. Calcium channel blockers like, diltiazem. So they work, many of them work more than just on the conduction pathways. They actually, because of the way they work, they will serve to lower your blood pressure. Because if your heart's not working as fast or as hard, if it's a negative inotrope, it reduces the strength of contraction, your blood pressure is going to drop, as well as your cardiac output. So I kind of like this. This also came out of the MedSurg book. Where do they act? So you've got stuff that works up in the hypothalamus. You've got things working on the baroreceptors. What are the baroreceptors? Where are they? Carotid sinus, in particular. What is it that what does a baroreceptor respond to? It's pressure, right. A barometer knows the pressure, the current air pressure, atmospheric air pressure. Your baroreceptors, they're going to respond to pressure, and that's typically due to, like, being fluid overloaded. That's what triggers you to pee, to make the hormones that make your kidneys work harder. Now, like a CHF patient, what's the brain natriuretic peptide actually do? What does it tell the kidneys to do? It says hold on to the water. So even though they're getting fluid overloaded, their system is deranged enough that they keep making this hormone that says, no, we still need more water. And that's why they start doing, fluid gain. And that's why it's diagnostic. The higher that BNP, the stronger is the body's impulse to not let it go. What's the highest BNP? Any of you remember? I know that some of my former med-surg students at least saw the occasional BNP in their stuff out there. What's the highest BNP anybody's ever seen in here yet? Or has anybody remembered ever seeing a BNP? Yeah, I think the normal range is up to like 400, somewhere around there. About a month ago, I was talking to a nurse about her patient. The patient had a BNP of 29,000. Needless to say, they were a little fluid overloaded. Which is why, my other discussion with my med-surg students is, don't tell me it's high. Because if you say high BNP to me, I'm thinking 29,000. Maybe it's only 900. So always make sure you include that number. Their BNP is elevated at whatever the number is. As long as it's, as long as you tell me the number, then we're both on the same page. I can't see my clock here. What time is it? 48. So like what? 10 minutes? Two. Well, guess what? We made it. You have 2 minutes to ask questions, and then you have to study for your next test. Quest, exactly. The quest for truth, knowledge, and everything.